I'm a patient. I just came in. I'm 38 years old. I've been trying for 6 months. What do I do now?
Sure. So let's start with just definitions, basic definitions of fertility. I think you hit it on the head, 38 years old. By the time you are at the 6 month mark, the majority of patients will have conceived, whether you're under 35 or over 35. Now, it happens to be the definition of infertility is if you've been trying for 6 months and you're over 35. If you're under 35, it's typically up to a year. What I always go through with patients is, okay, what are the different components that happen in order to conceive? And sometimes when I go through this, that's crazy that people even get pregnant. Right. But there's basically five main components. You've got your brain that we talked about earlier. So your brain sending those signals to the ovary. So the brain has to be able to send the signals. The ovary has to then respond, has to be able to receive that signal, grow an egg, and send signals back to the brain. When the egg grows, so you have to have a good number of eggs, a good ovarian reserve. Your egg grows, that egg gets released through the process of ovulation. Now, your fallopian tubes are not actually attached to the ovary, they're attached to the uterus. So they need to actually reach out and grab that egg as it's being released from the ovary and suck it into the fallopian tube. The egg will hang out in the fallopian tube for about 24 hours after it's released, waiting for fertilization. If it's not fertilized, it goes bye bye. It's gone. So I always say it's a little impatient, right? It's waiting. You got 24 hours. If you're not there in 24 hours, it's out. The next component, right? So we've got the brain, the ovary, the tubes. The next component is the sperm, right? So the sperm, when it's deposited through intercourse, average man, 20 million, 20 to 40 million sperm that needs to move. It needs to find its way through the cervix into the uterus, and not just into the uterus, but also find the fallopian tubes, which are these little tiny, teeny tiny holes at the top, and then go through those tubes and go into the right tube at the right time when the egg is there within that 24-hour period. So I always tell people, if you look at sperm under the microscope, it's just flopping around. It has no idea where it's going. So the age-old men don't ask for directions, biologically proven by looking at sperm. They have no idea where they're going. They're literally just bouncing around.
Numbers, baby. Let's go. Let's go.
So that's a critical component. And then the uterus, right? So if the egg and the sperm meet in the tube needs to be open so that the egg and sperm can meet. And it needs to be able to move through the tube and then drop into the uterus and find a place to implant. So those are the five components we have to look at. So we want to look at the shape of the uterus, make sure there's nothing abnormal there. We want to know that the tubes are open. We want to know that the brain and the ovary can communicate. We want to see what the ovaries look like on ultrasound. And then we want to do a semen analysis and see how much sperm is there. Most sperm is abnormal. 96% are abnormal. So we want to see of the normal sperm, how many are moving. And then we have an idea of, I call it targets, right? It's basically darts, and the egg is the target. So how many darts do we have and how many targets do we have available to us? So that's the general high overview of a fertility workup. So that includes blood work, looking at the brain-ovary communication, LH, FSH, estradiol, includes an AMH, which is anti-Mullerian hormone, comes from all the little eggs waiting to get used in the future. And that together kind of gives us an idea of, along with the ultrasound of the ovary, an antral follicle count, meaning how many eggs could grow in this cycle, gives us an idea of your ovarian reserve, and just helps guide us in terms of treatment, different treatment options. The ultrasound, while we're looking at the ovary, we also do a 3D ultrasound of the uterus, and then we do a semen analysis. And in many patients, we'll also do a tubal evaluation that can either be through something called an HSG, or recently I've been doing a lot of ultrasound foam. I find that it's a lot less painful for patients. I get a lot of the same information. The other thing that I like to always go over with patients is how to optimize natural fertility, right? So how do you optimize getting pregnant? And when I go through this with patients, I realize that for some reason, patients don't realize when is the best time to conceive. A lot of patients, when I ask them, they think it's the day of ovulation. And the truth is, the day of ovulation actually is a lower chance of conception than the 1 to 2 days before. So having intercourse the 1 to 2 days before ovulation is actually going to give you your highest chance of conception. And that's the benefit of using an ovulation predictor kit. That's exactly what they're doing. So I always tell patients, get an ovulation predictor kit, get a good one. I happen to like ones that give me that graph, so I can actually, it basically recreates what the menstrual cycle is supposed to look like in terms of hormones. So I can see for myself if there's anything off about the cycle.
What you say there actually is funny. It does backfire sometimes. You have no idea how many patients have come to my office and they say, Doc, I've been trying for 6 months. I've been using an ovulation kit. I wait until I ovulate and then I have sex. And I'm like,
Right. So the issue is if they're waiting for their progesterone to rise, that happens a few days after ovulation. So they've already
mhm.
missed the boat. When that LH rise happens, that says you're going to ovulate in the next 36 hours. And those next 2 days are going to be your highest chance of conception. So sometimes simply just literally timing intercourse correctly can help a lot.